Good morning. My name is Myra Smith. I'm the DMAS Payment Processing Supervisor. I'd like to welcome all of you today to our DMAS Hospital Billing Updates presentation. Thank you for your patience. We were anticipating 35 to 40 participants, but we currently have 82 participants in the session. So we're trying to make sure that we give ample time for everybody to get into the session. I noticed that from reviewing the attendee list, that we have attendees who are calling in via phone. With that being said, we would like for questions to be listed in our chat, and that's for those of you who have access to WebEx. For those of you who are calling in via the phone, when we get to the Q&A session, we'll give you ample time to have your opportunity to ask your questions also. The information that we're going to share with you today is can be found in a DMAS Medicaid bulletin that's available on the DMAS web portal, and it's dated July 1st, 2020. Our agenda for the day: we're going to go over the General Assembly mandate, which directs the information which we're going to discuss today. We're going to review preventable emergency room claims, preventable emergency room claims payment methodology. We're going to review inpatient hospital readmission criteria, the inpatient readmission payment methodology, inpatient hospital readmission exceptions, and then we'll address your questions. General Assembly mandated in the 2020 Appropriations Act, effective July 1st, 2020, that DMAS make hospital reimbursement changes for the following services: what we identify as preventable emergency room claims and inpatient hospital readmission claims. And we're going to review both of these hospital reimbursement changes separately. Next slide. Beginning with dates of service on and after July 1st, 2020, DMAS is going to review the primary diagnosis code for all claims billed with emergency room codes 99281 through 99284. Just want to inform you that there will be no change in processing for any claims billed with code 99285. The reimbursement and the processing of those claims will remain the same. If the primary diagnosis code on the claim is contained in the Preventable Emergency Room Listing, and that's an avoidable code list currently used by the managed care organization's clinical efficiency rate adjustments, DMAS will reduce the final payment based on an all-inclusive EAPG payment based on 99281 through 99284 using a fixed rate. All of these outpatient hospital claims for Virginia Medicaid are paid based on EAPG. And I also want to make sure that I inform all of you that all of the information that I'm discussing today applies to our fee-for-service claims. That's what I'm addressing. And we do have some information to alert you as to what the managed care organizations are going to do a little later in the presentation. For UB04 CMS 1450 claim submissions, prior slide, please. This information of the primary diagnosis code is reported in Locator 67. For those of you who submit your claims electronically, the information for the primary diagnosis code can be found in your companion guides. The payment. The payment determination will be achieved by calculating the rate for 99281 claims with a preventable diagnosis based on the data from fiscal year 2017 used in rebasing what was implemented in fiscal year 2020. DMAS has calculated a rate of 0.3085, and that's 0.3085 for 99281 claims with a preventable diagnosis code. The July 2020 release of the Virginia EAPG software by 3M will include a customization of this Virginia EAPG software that will implement this reimbursement policy for preventable emergency room visits. Again, note, there is no change for claims submitted and processed with code 99285. And again, if you have questions and you're online for WebEx, you can put your go through in chat. When we get to the questions, we'll read the questions in the order in which they're presented. And again, if you're calling in on the phone, we will give you also time to have questions answered also. Now we're going to talk about the Inpatient Hospital Readmission Guidelines. And again, this is effective 7/1/2020. I just want to note the Inpatient Hospital Readmission Guidelines for patients who are readmitted to the same hospital and within 5 days of being discharged for or similar diagnosis, this process remains the same. That means that the case will be considered a single case rather than two separate admissions. The readmission will be identified in the DMAS monthly processing cycle. The first claim will be adjusted to reflect payment for the combined case, and adjustment will be made to the second claim reflecting zero payment. And again, these steps reflect claims processing for DMAS fee-for-service only. The managed care organizations can have their own processing criteria. Two changes. Reduction for 30-day hospital readmissions, and that's for any patient who discharged from a facility, readmitted to the same facility with a same or similar diagnosis code within 6 to 30 days of the original discharge. That admission will be considered a readmission and subject to a reimbursement reduction. Guidelines are that the discharge on the first admission must occur on or after July 1st, 2020. Diagnosis is considered same or similar if the first 3 digits on the diagnosis code are the same. This is for a patient who was discharged from a facility and if the case is determined to be a readmission, again, within the 6 to 30-day time frame from the initial discharge with a same or similar diagnosis code, the first inpatient hospital claim will pay. The second inpatient hospital claim will also initially pay. During the monthly DMAS case building process, the second claim will be adjusted to pay 50% of the calculated payment as a stand-alone claim. The new policy does not apply to critical access hospitals. This policy applies to all other acute care facilities that are paid on the basis of the APR-DRG payment methodology. There are exclusions to the readmission process. Planned readmissions. Planned readmissions that will be excluded from the reimbursement reduction will be identified utilizing the procedures and diagnosis codes identified by CMS as always planned and or patient discharge status. CMS list of the always planned procedures and diagnosis codes are available with links in the Medicaid memo dated July 1st, 2020. Also excluded are always planned procedures and transplants. And note, DMAS, for the bone marrow transplant, DMAS does not reimburse bone marrow transplants by DRG. We will look at the procedure codes that you, the providers, bill to identify the transplants. And that's bone marrow, kidney transplant, or any other organ transplant other than bone marrow, cornea, or kidney. And again, we do not reimburse transplants by DRG with the exception of kidney and cornea transplants. Always planned procedures continued. The always planned procedures corresponding to the identified AHRQ clinical classifications, we have links to those also to be found in the Medicaid memo. Always planned procedures diagnosis also includes maintenance, chemotherapy, and radiology. Also, rehabilitation care, fitting of prosthesis, and the adjustment of devices. The diagnosis codes corresponding to these, we have links available in the Medicaid memo. Another piece of information that Medicaid will use to identify readmissions are the discharge status code. Any discharge status code greater than 81 indicate that the patient is being discharged or transferred with the expectation of a planned acute care hospital inpatient readmission. DMAS will use the criteria to capture other planned admissions that are not included in the always planned procedures and diagnosis list. It is very important for a hospital discharge staff to appropriately code the patient discharge status indicator in order for these planned admissions to be identified by DMAS. Also excluded from the readmission criteria, obstetrical readmissions. And DMAS will use the identified principal diagnosis code on the claim to identify it as an obstetrical readmission. And again, a list of these can be found in the Medicaid memo dated July 1st, 2020. Patients who leave your facility against medical advice, DMAS will use the discharge status code on the first admission to identify this was the case on a readmission. And of course, that discharge status code is 07, left against medical advice. Some billing reminders. Discharge status information, and we go by the UB04. So when we have the information in the DMAS manuals, we always talk about paper claim guidelines. If you need electronic EDI guidelines, that information can be found in the companion guides on the DMAS web portal. For your UB04, the discharge status is reported in locator 17. Primary diagnosis code is located in locator 67, and the procedure codes are located in locator 74. The APR, DRG, Virginia Medicaid inpatient hospital claims, the payer provider can use this information to can use the information identified here to identify claims that meet the readmission criteria. I made a note on that. The 3M DRG software for Virginia is scheduled for a July 9th release, and it will also provide a flag for the provider, which you'll be able to use to identify that the claims that you are submitting meet the readmission criteria. Also want to remind you that the Medicaid memo, which is available on the DMAS web portal, has all of your links for the procedure codes, diagnosis codes, for the readmission criteria, has a list of the preventable emergency room diagnosis codes. Also, I want to give you, the provider, a update on the error codes that will identify these reductions. For the preventable emergency room diagnosis codes that are reduced, your error code will be 2102. For the hospital inpatient claims that have been reduced based on the readmission criteria being matched on your claim submission, that hospital readmission 6 to 30-day reduction will be identified with a error code 2103. Before I get to questions, I have a note. These policies also apply to the managed care organizations, the MCOs for Medallion 4 and CCC Plus. However, their processes may differ slightly. You would need to reach out to each of the managed care organizations for their criteria. With that being said, I have one question in my chat, and it states, what is the impact of these changes on freestanding inpatient psychiatric facilities? When you say primarily the managed care organizations, all of your questions for the managed care organizations, I recommend you reach out to them individually to direct your questions to them, because they can have specific criteria to their plan. And for it says the arts player. And our arts payer currently is Magellan. If I'm not mistaken, our psychiatric admissions, I'm going to defer, because prior to us securing our art services through Magellan, our claims for psychiatric were reimbursed a certain guidelines criteria. I'm going to reach out to our Magellan staff in behavioral health and obtain the response for your question, because I don't want to misspeak. And everyone who has registered with your email address, once I get the response from our behavioral health staff, I in turn will send that response to everyone. I just don't want to misspeak. Again, for the managed care organizations, you would need to reach out to each plan individually for their guidelines on psychiatric criteria. I am going to make sure that I get the correct response for our Magellan services and share that response with everyone in attendance that I have your email address. Next question. Are professional CMS 1500 claims affected by both of these reductions? The reduction for the emergency room does apply to the emergency room physician services. We have a session scheduled for 1 o'clock to discuss that for the professional side of this. As far as the readmission, there is no reduction for the physicians. The readmission reduction applies to hospital services only. So it's just the inpatient hospital bill that the reduction will apply for the readmission. All right. I don't have any additional questions in our chat. I guess if you have a question, I guess we can unmute your phones as far as our people who called in. Please understand that we have over 45 people who called in, so we can't all talk at once. But if you have a question and you called into the session, then we in turn want to open it up so you at least can ask your questions.
All right. So, Myra, before we do that, we have a couple of questions in the Q&A box. I don't know if you can see it, but they want to know if the presentation is going to be shared.
Yes. Question. Will the presentation be shared? Yes. Because we had great attendance today. If you've registered and we have your email address, we will share the presentation with all who've registered.
All right. Next question. Has DMAS estimated the revenue impact that will impose on Virginia hospitals?
The question, has DMAS estimated the revenue impact? I am not in the provider reimbursement division, but I in turn will take your question and direct it to the provider reimbursement division for response.
Thank you. Next question. Is DMAS launching an educational effort to ensure patients utilize the ED appropriately?
The question, is DMAS launching any educational endeavors for our Medicaid population? I, in turn, will take that question back to our team at DMAS and ask the question so I can give you a response.
Very good. Thank you. Now we're going to open the lines. So what we're going to do, I'm sorry.
I said thank you, Ms. Jones.
You are very welcome. All right, Myra, while we figure this out, I believe you got a few more questions through the chat box.
I see it right here. We have a question from Michelle Green. Can we appeal these with records for further review? You, as a provider, have the right to appeal. And again, with an appeal, you need to submit all of your justification to support the claim that you submitted to Virginia Medicaid.
Okay, so that's not going to work. So we're not going to be able to unmute those who have questions. What we would like you to do, if you have questions, please send your questions in to the TURA at Myra. Do you have a unit email address that we can use?
I'm going to just put it out here, and I will accept questions today. You can email me directly. I will give you my email address, which should be on the last slide of this presentation. For those of you calling in, I'll give you my email address. And any questions that are received today, I will address them or direct them to the division at DMAS that can give you a response. My email address is Myra, MYRA, .Smith at DMAS, DMAS, .Virginia spelled out, .gov. And again, your questions, any questions that we can readily answer, you get a response to. If it's a question which needs to be addressed by another division at DMAS, we will send that question to that division. Once we get a response, we'll share it with everybody that we have an email address for. And again, questions received today. Question in our chat box. Can you share on the DMAS website where the memo is located? The memo is located on the DMAS web portal. I'm going to go now so I can direct you how to get there. On the DMAS web portal, under Provider Services, you have a link that says Medicaid Memos and Bulletins. Once you select that, then the years come up. You need to select year 2020, and the Medicaid memo is dated July 1st, 2020, and the subject is reimbursement reductions for preventable emergency room visits and hospital readmissions effective 7/1/2020. And I'm going back to the chat questions again. When you say that the MCOs will put their own program in place, they don't have to follow the DMAS memo, though. The MCOs have their own specific criteria. They're going to have different guidelines or additional guidelines that they may put in place. That's why we want you to reach out to each of them individually for their guidelines. But as far as the reduction, the basic guidelines, yes, they also apply to the managed care organizations. Next question. Are there any age restrictions to the emergency department reduction? For example, do they not affect patients under 12 years old? I was not given any information that there was an age restriction on the emergency room reduction, but what I will do is take your question back to our provider reimbursement staff and ask the question.
You have another question in the Q&A.
Okay.
Is there any incentive or penalty for patients to not use the ER unnecessarily?
That's one of the questions that would go back to what type of education that we're going to give to our Medicaid population. I'll add that as a second part to the question.
Very good, thank you.
I have a question in the chat box. What is the exact link to the ER diagnosis codes deemed preventable? Within the Medicaid memo, if you go to the DMAS website for the memo, the preventable emergency room diagnosis codes are listed out. It is a 40 or 50 page memo. I did have it up this morning. So all of the diagnosis codes that we think preventable for the emergency room are listed. So you go to the DMAS website, bring up the Medicaid memo, scroll through it. The preventable emergency room diagnosis codes are listed at the end.
Myra?
Yes, ma'am.
Oh, okay. I thought you faded out. Sorry about that.
No, ma'am. I just turned my head.
Okay.
All right. Again, I am opening up my email today for your questions. And again, the questions that you send today, if it's something that we can identify within the memo, we'll direct you to it. If it's questions such as for the managed care organizations, our process is you reach out to each one of the individual plans. And if there are questions such as information or education for our Medicaid members, I in turn would have to ask that for other divisions in Medicaid, and we'll need to get a response to come back to you. Okay?
All right.
Thank you for your patience with us during this process. We wanted to make sure that we shared information as soon as possible, and with participants calling in, we in turn tried to open it up, but as you could see with the feedback, we couldn't. Technically, it was not an option. So again, I ask that you respect my email address and send your questions in today. We will try to review them and get your response back as soon as possible. And what we'll have to do is compile all of the email addresses for everyone who registered so that we in turn can do a response to everyone. And again, let me give you my email address for those of you who are on the phone. It is Myra, MYRA.Smith at DMAS, DMAS, Virginia spelled out, .gov. Okay. And again, we're going to also share the presentation with everyone who's registered where we have your email address. Make sure I don't have any more chat questions. Okay. I thank you for your participation.
All right. Thank you, everyone, for attending today's session. Down at the bottom portion of your screen, if you click on the X, it'll log you out of the event. And again, thank you for attending our session.